So welcome everybody. I'm going to introduce Dr. Lunn, who is our speaker for today. Mitchell Lunn is an assistant professor in the Division of Nephrology of the Department of Medicine at Stanford University School of Medicine, and an assistant professor of epidemiology and population health. He is the co-director of the PRIDE study, an online national longitudinal cohort study of over 20,000 LGBTQ+ participants, and is the co-director of PRIDEnet, a national LGBTQ+ community engagement network. Mitch has a special interest in using technologies to support participant recruitment, cohort management and retention, and results dissemination. Clinically, Mitch provides adult primary care in Stanford LGBTQ+ Health Program and attends on the inpatient nephrology consultation service at Stanford Hospital. Mitch earned his Bachelor of Science degree with highest thesis honors from Tufts University in 2004, his Doctor of Medicine degree from Stanford University School of Medicine in 2010, and his Master's in Advanced Studies degree in Clinical Research from the University of California, San Francisco in 2017. He completed internal medicine internship and residency training at Brigham and Women's Hospital in 2013 and nephrology fellowship at UCSF in 2016. Welcome, Mitch. Thank you so much for being here, and I'm going to hand the mic over to you.
Great. Thank you so much, Dr. Norwood. It's really a pleasure to be here and to participate in this Pop-Up Research Institute. You guys have been very busy over the past month with lots of events, and it's been really great to see some of those. I'm delighted today to be here to talk to you about our principal research project, which is called the PRIDE study, and how we bring community engagement into that to improve the health of LGBTQ plus communities. So, of course, the obligatory disclosure slide have received funding from the National Institutes of Health, as well as from the Patient-Centered Outcomes Research Institute, or PCORI, but I have no relevant professional or personal conflicts of interest related to this presentation. I usually start this with a discussion about who I am and what my identity and pronouns are. So my name is Mitch. I'm a gay cisgender man. I'm originally from North Dakota, where I grew up until I went to college in the Boston area when I was 18. I use he, him, and his pronouns. And for those of you that are live tweeting this, feel free to tag the PRIDE study here. Today, I'd like to tell you a little bit, just very briefly, I think probably not unknown to folks in attending this talk, are some basic population estimates and statistics about the sexual and gender minority population as a whole, as well as just a very quick laundry list of some health disparities, which I imagine many folks on this presentation have heard about, or at least maybe remotely familiar with. Spending then a majority of the time discussing the PRIDE study and how we do community engagement in the PRIDE study, and then a brief look at the PRIDE study's future, and hopefully some time at the end here for questions from you and a discussion. So we can start with SGM, or sexual and gender minority people, and some of the health disparities. And just to level set here, there have been, as I think many people are aware, many different terms like LGBT, LGBTQ, LGBTQIAA, LGBTQ+, a large, really veritable alphabet soup of letters that constitute an acronym. And academic medicine created this term now almost probably 10 years ago of sexual and gender minority, that has also now slightly changing to sexual and gender diverse, or SGD. And really, all of these are terms that are umbrella terms to reference people who are not heterosexual or are not cisgender. So cisgender just refers to folks whose gender identity aligns with the sex that was assigned to them at birth. And so I use these terms rather interchangeably throughout this presentation. And so you'll hear me say LGBT, LGBTQ, and SGM rather frequently. But really I'm referring to this entire population of folks who are not heterosexual or who are not cisgender. And we don't, for reasons that we'll go into, we don't know for sure the number of people in this country that identify as LGBT or as a sexual or gender minority person. However, Gallup calls people every day and asks them a question, which is, do you personally identify as lesbian, gay, bisexual, or transgender? And you can see over the years from 2012 to 2017 that percentage has been increasing, and roughly 4.5% of the Gallup respondents answer yes to that question. And on the lower graph on the left-hand side there, the green line at the top, that lime green line, that's 8.2% in 2017, is the millennials. So this is not that LGBT people are becoming more common. It's more that society has changed, where coming out to and answering affirmatively to this question that Gallup asks you on the telephone is becoming a more comfortable and more socially acceptable for people of a younger cohort compared to the traditionalist people born in the years of 1913 to 1945. We also know that sexual and gender minority status or identity is not unique to a particular race or ethnicity, and it's not also not unique to a particular income bracket or education levels. And so, as I like to say, SGM people are everywhere in every part of this country, in every county of this country, and represent really the whole diversity of the U.S. population. And wouldn't it be nice if we could have more robust estimates of SGM people? And really, sexual orientation and gender identity, have not been collected and are currently not being collected on the U.S. Census, which is of course conducted every 10 years, including actively being conducted now, wrapping up soon, of course. And this was initially planned to be in the 2020 census, but was eventually removed by under this administration from the 2020 census. So we'll really need to wait until 2030 for really a robust estimate of sexual orientation and gender identity of the population, which of course the Census Bureau and the data that it collects are used for numerous epidemiological sampling frames and other aspects of figuring out where SGM people are. The Census Bureau conducts what's called the American Community Survey in the intervening years between the decennial census, and so it would be great for sexual orientation and gender identity to be included in the American Community Survey in one of these upcoming years, hopefully as well. And then I just wanted to briefly touch on health disparities. Many, I think, are familiar with them, but really just again to level set that homosexuality was considered a mental disorder in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, until 1973, and gender dysphoria remains in the current edition of the DSM, which is the DSM-5 right now. During the genetic era, so thinking of the 1990s or late 80s and 90s and into the early 2000s, when the Human Genome Project was being completed, that there was at that point began the hunt for a gay gene or a trans gene, as if this were some mutation that people could fix. And there has been a variety of conversion or kind of reparative therapies to really convert people back to either a heterosexual or cisgender identity. These are commonly religious affiliated organizations that have conducted these. These have been found over and over again to be detrimental to people's health and have been outlawed in many states of the country. On the top part of this slide, I use this as a reference to negative experiences that happen in the healthcare providers' offices. And so this is from the 2015 transgender survey. And on the graph on the left, you can see the orange bar with 33% of transgender people have had one or more negative experiences with a healthcare provider in the past year. And on the graph on the right, 23% of them have actually not seen a healthcare provider out of fear of mistreatment in the past year. You can see from the blue bars there that this is not unique to a particular racial or ethnic group. And so with a quarter to a third of people not seeing the provider or having a negative experience, you can imagine that folks may not seek out healthcare early, may not seek out preventative healthcare, may not seek out healthcare until there are late stage presentations of diseases, including cancer. On the bottom part of this slide recognizes that smoking is probably the LGBT community's largest health burden. We smoke 2/3 more than the general population. So 1/3 of LGBT people smoke compared to 1/5 of the US population, spending billions of dollars a year and taking many years off of our life. It's important to note that in the 90s, when there were a lot of big tobacco settlements that were happening, a lot of documents became unclassified, and marketing campaigns that were specifically targeting LGBT people were uncovered from the big tobacco agencies. And so they were ones that have been, frequently with us in terms of marriage equality and equal rights in their advertising, and simultaneously have been, selling us on their addictive and cancer-causing products. On the top here is a really sobering statistic that 41% of transgender people report having attempted suicide in their life, compared to 1.6% of the general population. And this is, of course, from societal stigma and discrimination that leads to these poor mental health outcomes for SGM people, but especially among gender minorities. And so this is really a notable, cry for having gender affirming healthcare, as well as, gender affirmation in society. And the bottom part, figure here is showing that about 40% of the homeless youth in this country identify as LGBT, compared to about 7% or 8.5% of the population in general, of youth population in general. And of course, this is because youth experience homelessness for a variety of reasons, but often includes being kicked out of their household for being LGBTQ, or leaving their household out of fear for their own safety. In San Francisco, because San Francisco is known, as a safe place for LGBTQ people, we know that the homeless youth population, more than 50% of them here identify as LGBT, as people oftentimes come to this area for all the services and acceptance that San Francisco has. So that's kind of a whirlwind of the SGM population overall, as well as just a few select healthcare disparities. There are, of course, many, many more, and it could be several entire presentations to discuss those and go into the details. But I'd like to move next on to tell you a little bit about the PRIDE study. And first, I'd like to, the focus of a lot of today's presentation will be on community engagement and some of the aspects that we do to make sure that our study is in partnership with the community. And so I'd like to start by sharing a video with some community members. And the audio should hopefully work for people. The video may be choppy over Zoom, but I think the audio will share a lot of the sentiments.
Are we good with the sound? Okay. I'm a Russian-speaking, gay, Catholic,
Chinese, Mexican,
Latina,
white male,
biracial,
bisexual,
trans woman,
lesbian,
Colombian American.
I kept trying to come out to my parents, but they really don't understand.
I mean, I like being a lesbian.
I don't wish I was straight at all. I think that this makes me special.
And especially in this time and age, being gay is seen as an asset.
The person who really is most accepting of my transgender identity is my mom.
She came at me with a knife and screaming that she would rather see me dead than living the life that I was living.
I knew that there were aspects of who I was and how I was in the world that were not welcomed in the medical world.
When I visit a new doctor, it's always a challenge.
I had colon cancer about 10 years ago.
One of the first things I feel like I have to do is kind of dispense with this notion that I'm straight. So what are you using for birth control? And I said, nothing.
You don't want to go into a clinic and then end up having to educate your own doctor.
And she just stopped and she looked at me like I'm an idiot.
That's what they're there for. They should already know.
You know, going to the doctor should be a safe place.
I try to avoid situations where I feel like I'm going to be stigmatized or discriminated against, but I know that that is something that I can't always control.
Our community has gone through an enormous number of hard things over many, many years.
You know, thing after thing hits us, and we always come back.
I mean, really, the community provides, in many ways, everything.
We really need to join together as the diverse and dynamic communities that we are, and help to transform the health system together.
I always feel that if my struggles can help someone else not have to go through the same thing I went through, then it hasn't all been in vain.
All right, so the PRIDE study, like many studies, is an acronym. It stands for Population Research in Identity and Disparities for Equality. And we have this kind of overarching, not really a research question, but a driving question of how does being a sexual and/or gender minority person actually influence your physical, mental, and social health. And while you know, I'm one of the co-directors, and my friend and longtime friend and colleague Juno Obedin-Maliver, who's an obstetrician and gynecologist, is the other co-director, we're not just interested in the physical health components of things. We have an associate director who's a clinical psychologist, and many other folks involved that focus as well on the mental and social aspects of health. So we really try to take a broad and holistic approach. And we have an engagement philosophy. And I like to start in the upper right-hand corner, which is participants know best. And so we, you know, academic medicine is great for and is popular for having faculty members like me and, you know, academics come up with research questions that they think are important, when in actuality, we want to do things that the community would want us to study and what their priorities are rather than mine or Juno's, for example. Additionally, we feel like there's a need for research studies to actually give back to SGM communities. SGM community members are participating in our research studies, providing feedback, serving on advisory boards and other ways. And so it's really important that this is a bi-directional relationship and not just us as researchers using, and I use that word intentionally, using the LGBT community for our research purposes. Community engagement is really an important aspect of what we do, and we usually use the terms engaged end to end, meaning that community members are involved from research design all the way through recruitment to data analysis and interpretation to results dissemination. So really from beginning to end of a research process, we want to make sure that the community members are really involved. I shared some statistics earlier that folks have had negative experiences in the healthcare providers' offices. So getting them to come to an academic medical center like Stanford or like UT Austin or others is sometimes hard because the experiences that they've had are really negative, from being misgendered by a welcome in a kind of a customer service or an orientation, somebody at the information desk, to the valet parker, to other approaches, are things that turn people away from coming into our places where research is typically conducted. And additionally, we want this to be a low burden. Again, people are taking time out of their lives and days to participate. We want this to be easy, and sometimes driving to a clinical research center, arranging for parking or childcare or time off from work are all things that are really hard to do. So an overview of the PRIDE study is that we're a national study. We are online only. There are no in-person visits. I've never met 99.99% of the participants in the PRIDE study. And we're a prospective longitudinal cohort study. And we add the word dynamic because unlike some cohort studies, we don't have dates of or waves of enrollment where we're open for enrollment between a particular, a year or a couple of years. Instead, we're open all the time. And so people can come and join the study at any point and not and hopefully they can also withdraw at any point, and we hope that the numbers coming in are more than the numbers leaving. Right now, the inclusion criteria are to identify as a sexual and/or gender minority. Again, there's no test or quiz or blood test for that. You have to be an adult right now living in the United States or its territories, and right now we're only in English, and these, of course, are the things we would like to eventually move towards are having ages under 18, say 12 or 13. Obviously, identity formation happens in everyone before they're adults, or at least starts, and in languages other than English. Of course, Spanish would be the next language that we would go to. The PRIDE study has had 2 phases. The first phase was a rather long, about 20 or 22 month long community listening phase. Some people call it a pilot phase. And this is when we had an iPhone app, and we were on iPhone only. And the purpose of this phase really was to generate health related research questions and research priorities from the SGM community themselves. We also pilot tested some health surveys and wanted to then use this input to generate really phase 2 of the research study. During phase 1, we recruited about 18,000 people via this iPhone app, and then phase 2 began in May of 2017. We developed a custom-built web platform. We obviously moved away from being iPhone only, as that, of course, has numerous limitations. And this custom-built web platform really, in a way, it has a participant profile, much like LinkedIn or Facebook or any of these, that collects, in this case, relevant demographics, including sexual orientation, gender identity, and sex assigned at birth. A significant amount of medical and surgical history and medications that you take. The longitudinal part of this collection includes an annual health questionnaire that we release every June. So every Pride month, we release the annual questionnaire. It's open from June through May of the following year. And that's a longitudinal instrument, which I'll go into detail a little bit later. And then we have ancillary or topic-specific studies that are much more in-depth, much shorter studies or surveys, but much more in-depth on a particular topic. And those are proposed by people within our group as well as outside collaborators, and I'll talk more about that as well. We've enrolled now over 20,400 people in phase 2. So going back to the community listening phase, this again was a pilot that lasted about 22 months or so and was designed to generate research questions. And it was also really a take-home point of this was whether or not we could actually recruit sexual and gender minority people. They've long been described as an understudied and underserved population. They are recognized as a health disparity population for research from the National Institutes of Health. And the shorter answer is that yes, we were clearly able to recruit these 18,000 plus people. We have sexual orientation, gender identity, and sex assigned at birth on about 16,300 of them. You can see here, and I think we like to show this when was the last time you saw sexual orientation and gender identity in a table 1 in a paper that you read in whatever journal is your favorite journal of your field, whether it's, if you're in medicine, of the New England Journal of Medicine, of JAMA, of Annals of Internal Medicine. When was the last time that you saw sexual orientation and gender identity there? And so one of the points that I like to share here is this is something that we can all start doing on all of our studies, no matter whether they're for sexual and gender minority health related topics, or is it just a research study that you conduct on diabetes or on hypertension or on cancer. And so the importance of starting to ask sexual orientation and gender identity on from every participant in every research study is important. We have obviously a rather diverse selection here, and you can see that that many folks selected more than one sexual orientation. 16.7% selected more than one of these sexual orientation options, and 6% of folks selected more than one of those gender identity options. And so really it's an aspect here that SGM people will participate in research if they feel that it's safe for them to do so. And so the community forum aspect of this really just posed a simple question to folks, which was, what do you care about? Post a topic you would like researchers to study about the LGBTQ community. And this was a discussion board style approach where about 3,500 different topics were posted, and people could then add comments and start a thread of discussion. We had about 5,000 different comments posted, and then people could vote these up or down, like Reddit, for example, and add their like or dislike of a particular topic. These are not in particular orders, but some of the top things that did come out of this list were a lot of issues that related to mental health as well as social health. So thinking about depression and anxiety, the role of family support, violence in our community, how some intersectional identities, how race and ethnicity along with SGM identity affected people's people's experiences, and the need for LGBT competent healthcare, and really where people were not teaching their providers what they needed. And so this, of course, was a monumental effort of coding these, nearly 9,000 topics and making sure that that all of these were done in a qualitative analysis way. And this paper is actually under review now. And so we're excited that this really has informed a lot of what we do in phase 2 and some of the studies that we're conducting now in the longitudinal aspect of the PRIDE study. And this will be published soon for other researchers to see that these are some of the priorities that the LGBTQ+ community has. So phase 2, as I mentioned, was launched in May of 2017. This is the web-based platform, and this is my caution for whenever you're speaking casually with a reporter, that sometimes it ends up as a tweet, not much longer, not much later. And so really the iPhone, of course, is not diverse enough. As much as Apple would like everybody to own an iPhone, we know that was not a way to reach really a diverse group in terms of both socioeconomic status, race and ethnicity, and in many cases geography. And so instead, we ended up developing our own research platform. For those of you that are technologists in the audience, this is a rather complex diagram about our microservices-based infrastructure. This was initially deployed in Amazon Web Services. We've now transitioned it to Google Cloud using a containerized approach. And this was really a demonstration that we were, of course, able to create this research infrastructure, and it's, I think, useful for not just the PRIDE study, but for other longitudinal online studies. And we can talk a little bit more about what this looks like. And so this online research platform looks like this. When people come into their dashboard, they have an area of various activities to do, and this is making sure that their my profile, which is their demographic information, for example, date of birth, sex assigned at birth, gender identity, sexual orientation, race, ethnicity, education, etc., that information is complete. We also ask a laundry list of various medical diagnoses that they have, including things like hypertension, diabetes, kidney disease, epilepsy or a seizure disorder, and many others in the My Health section. And people also list their medications based on kind of a live completing list of medications from a database. Obviously the most important part here is accessing surveys, where people can access both our what we call our lifetime questionnaire, which asks about questions or things that have happened in people's lives, and then the annual questionnaires, as well as the ancillary studies shown here as the skin or the sun and skin survey, for example, is one ancillary study asking only about ultraviolet exposure. Further down, you can see that there are some live statistics about the number of surveys that this person has completed over time, as well as how their demographic selections compare to other people in the cohort. And so this is the description of this platform is available from this paper. And we also have a set of kind of cute images to encourage people to continue completing various sections. And these are really, we found to be quite motivating and help people, proceed through and achieve some data completeness. We like to think that we're the only academic paper that we know of that has a rainbow unicorn as one of its figures. So, this I think this paper does explain some of the other cohort retention and other aspects that we've created for data completeness. I wanted to move on to the annual questionnaire because I think that's important. And I mentioned that we'd have both physical health, mental health, and social health components. I've just listed 3 topics in each of these. The annual questionnaire is quite substantial. Takes about 45 minutes to an hour to complete. Again, it's once a year, so we oftentimes use the term 1 hour once a year is your PRIDE study commitment. It asks, a variety of topics, some of which are shown here. And for the most part, we try to use standardized instruments that have been used in other health surveys. So the PHQ-9 for depression, for example, the PCL-6 for post-traumatic stress disorder, and the audit, the full 10-question audit. Many people are probably familiar with the audit C for alcohol screening, the short questions, but there is a 10-question audit to look at alcohol use disorder broadly. And we use a variety of other measures. People may be familiar with the PROMIS measures and others that looking at general health or measures of other standardized instruments that are out there. Occasionally, we've needed to make minor modifications to them to be LGBTQ plus appropriate. Some of them use language that is very, heterosexist or cisgendered, and so we really want to make sure that the language is appropriate. And then we have a very complex set of branching logic. People ask or answer some questions early in the survey that then guide them down various branches that are more applicable to their unique experiences and identities. We have created some of our own measures as well for specific experiences that are unique to LGBTQ plus patients and participants. So one example that we've done, and this is using annual questionnaire data, is looking at gender minority use of alcohol. And some of the alcohol use disorder screening instruments that we use in primary care, for example, have different cutoffs of the number of drinks in a certain period of time. And those cutoffs have been based on people's sex assigned at birth. And so the question we asked is, are those same questions using sex assigned at birth appropriate for gender minority people, or are there better questions to use? And so we had about 1,900 gender minority people from the PRIDE study participated in this particular item, and this study, and really asked. We tested a variety of screening questions to see which ones best predicted harmful alcohol use and alcohol-dependent symptoms in the past year. And we looked at various gender minority subgroups and actually found a single item, regardless of people's which subgroup they were in, regardless of what sex assigned at birth they had assigned to them, a single item that had maximal sensitivity and specificity. And so, this is one way in which we can slowly start to impact the primary care experience for SGM people and asking questions that are a little more appropriate. We also published this paper in the Journal of General Internal Medicine about suppression and anxiety changes among SGM people with COVID-19. And so we use data from the 2019 annual questionnaire, that's time point 1, and an ancillary study that was called the Coronavirus Impact Survey, that's time point 2, and looked at how folks' depressive symptoms and anxiety symptoms using the PHQ-9 and GAD-7, respectively, how those changed over time. And we, of course, saw increases in both depression and anxiety, as I think we're hearing in many populations. But this was actually largely driven by participants who didn't screen positive for depression or anxiety at time point 1. And so that's not necessarily meaning that that those folks still are not having depressive and anxiety symptoms, but it was, there's lots of hypotheses about why this is the case. Perhaps folks who have lived with depression and anxiety for a long time have developed, different coping mechanisms and are able to have some resiliency in the setting of COVID-19 compared to folks who have not. And so there's, some interesting the use of longitudinal data, I think, is demonstrated here. And then we have a collaborating investigator, Jason Nagata from the University of California, San Francisco, who has really broken new ground in the eating disorder realm for sexual and gender minority people. And so he's now looked at one established questionnaire, one instrument called the Eating Disorder Examination Questionnaire, or the EDEQ, and these were previously, unstudied populations in the eating disorder literature. And because the PRIDE study has so many people of so many different identities, we're actually able to disaggregate the LGB, the T, the Q, the plus into separate groups. And so you can see here that these papers are really, different subgroups, and we have upcoming, Jason has upcoming papers using the bisexual plus community and a paper with gender expansive folks. And then, additionally, this is just the EDEQ, but there are actually upcoming manuscripts using other components of eating disorders, including muscle and body dysmorphia, the use of anabolic steroids and performance enhancing substances and drugs and supplements, et cetera. So this is really just the way that an ancillary study investigator can really move forward with a lot of breaking new ground in the SGM community. I wanted to dive a little bit deeper into community engagement, and I think we view community engagement more on the transformational spectrum rather than the transactional spectrum, which is do this, take this study for me, and instead we want to create activities that really involve people in meaningful ways in our projects and in our research efforts. And so it's the let's partner together and do something better together. And so PRIDEnet has several components. Aside from PRIDE study participants, we also have a participant advisory committee, a community partner consortium, and a group of ambassadors. And I'll talk about each of these briefly. This image on the right-hand side here really is those same 5 community engagement principles that I talked about earlier, and they're really important to note here is that one of the ways that we keep the community engaged from end to end is that we employ participant feedback. And so we review feedback from our advisory groups, but also from our participants who send stuff in. There's an easy way for folks to provide feedback to us about their experience in the PRIDE study, and we review that feedback on a quarterly basis and then make changes as needed to our research or to our methods based on the community. So our participant advisory committee is shown on the left-hand side here, currently 11 members, soon to be 12, made up of folks across the country from various organizations and have various roles that really represent and provide a geographical as well as other diverse viewpoints that we might not have just from our group here at Stanford. They meet monthly for 2 hours to discuss our projects. We present to them, they present to us, they review applications for ancillary studies. They do really a of work, and we're very grateful for them. They are, of course, compensated for their time and effort. And then similarly, we have ambassadors, currently these 8 folks shown here, and these are, you can think of these as engaged and well-connected SGM people across the country. They may be connected personally in their personal networks or professional lives to large numbers of LGBT people. Some of those connections are online, some of those are in person, and of course that's everything is moving online in the setting of COVID. And then we also have a set of community partners, which are LGBT serving organizations across the country. And so these are LGBT health clinics, LGBT community centers, and other service and advocacy organizations. And so a shout out to the Trans Forward Texas Transgender Health Group, one of our great community partners here. But you can see some are large and some are small, people like Fenway Health in Boston and the Human Rights Campaign, compared to smaller community centers in more rural or suburban areas. And so really a set of engaged organizations that do a variety of things with us as their scope and capacity allows. And then some community engagement examples we do have. We create our Participant Advisory Committee created this guidance for community engaged research document that's shown on the right here. This is really a 30-ish page document that helps people understand how to conduct research with LGBTQ+ communities. And we find it to be really informative to our ancillary study applicants, people that are applying to collaborate with us. And you can see some of the other activities, which I won't go through here through on the screen. And then finally, we do conduct a variety of community listening sessions, and this is where we go to meet with people across the country and listen to their opinions and experiences, specifically their opinions about participating in research and some of the health issues that they face. And this really gives us some on-the-ground insights from real live LGBT people and helps us really adjust our approaches and helps us understand some of the barriers that we need to help people get over, help overcome those barriers to participate in research and get the healthcare as well that they need. Similarly, we hear about some of the facilitators or other aspects that are really relevant. And then for the last few minutes, I'd just like to discuss some of the PRIDE studies' future. And part of that is ancillary studies. So in addition to that annual questionnaire that we release, we do have an ancillary study process. And this is really a collaborative process where we partner with both academic and community-based researchers to ensure that ancillary study research questions are getting answered. There are two types of ancillary studies. One is using the data that we already have to do analysis on that data and answer a particular research question. All of our surveys are posted on pridestudy.org/collaborate. Additionally, if you have a new survey on a particular topic that you're interested in, we could disseminate that survey or biospecimen collection process or other, even an intervention to the PRIDE study participants or a subset of them as well. And so this is done through an online proposal form that is at pridestudy.org/collaborate. And the next slide is not to scare people, but really just to highlight that the bottom kind of left corner where there's the RAC, the Research Advisory Committee, and the Participant Advisory Committee, the PAC review, you'll note that both of these happen. And so an ancillary study application undergoes scientific review as well as a community review by the PAC members, the Participant Advisory Committee members, and their review is given equal weight to the scientific approach, to the scientific committee. And so if the PAC members, if the community members say that this study is bad and needs to be revised for whatever reason, the study doesn't proceed. And so we take they take their opinions very seriously and really only want to do work that is going to benefit the LGBT community. And so it really is a back and forth process with the ancillary study investigator to make sure that that an application really is the best that it can be as it moves through this approach. Here are just some, and I'm not going to read these, but some of the ancillary studies that are either approved or even have been completed, and papers are coming out on these, on a variety of these topics, or analyses are underway. So there's really a huge array of things, including things that are not necessarily particularly immediately what people think of when it comes to health. For example, employment rates and discrimination. We obviously know that employment and health insurance coverage from employment helps with with health as well as people's income. And so we really again take this rather broad holistic view of things. Looking forward, we're looking, there are many pros and cons to doing online only research, including some of the difficulties for keeping people engaged and retained. And so we're looking at a variety of employing and testing out some new retention techniques. We're always looking at ways to deliver value to participants and thinking about ways in which, what do they get from participating? Because right now we don't pay people to participate. We don't provide an incentive. Some surveys have incentives for a drawing, for example. You could, $125 gift cards or things like that we get given away randomly, but it is that is not the only type of value that we can deliver. And then moving into soon, later actually this year and early next year, into biospecimen production. And so and collection of biospecimens in various ways. One of the aspects that we haven't gotten much pushback from folks, but is an important aspect, is we don't know that Mitch Lunn is Mitch Lunn completing the surveys at the other end of the computer screen. We don't verify people's identity. You can imagine that this is challenging in especially for gender minority people who may not have government or identity documents that fit their current gender or their current name or even a current photo. And so there's some challenges with this, but we're exploring different ways of doing digital-based identity verification. We have a study that's in the pipeline, which we haven't launched yet, that we're going to try doing some health record adjudication of certain cardiovascular related endpoints for a subset of people who participate, and seeing how well people can provide their information about their prior cardiovascular events, and then take a look at their health records and see, compare, make sure that that is accurate and correct. And then I think much later down the line is data linkage to a variety of other data sets. So there's a large clinical data research network called PRIDEnet, which is now run by the Patient-Centered Outcomes Research Institute, PCORI. There's the All of Us research program, which is the NIH's Precision Medicine Initiative, as well as other data sets that are not even health related, that are more neighborhood based, or others that may be informative to tell information about the health of neighborhoods, for example. So I want to save some time for questions. So let me wrap up with just a few take-home points that sexual and gender minority people are really an underserved, understudied, and vulnerable populations that we don't know exact numbers of in this country, but we do know that there have been health and healthcare inequalities and inequities that are there. The PRIDE study tries to provide really a comprehensive data collection mechanism through our annual questionnaire that takes about an hour to complete, as well as rather collaborator and investigator proposed ancillary studies. We think that community engagement is important in all aspects of the research process and really improves the researcher community relations. Mobile and digital technologies are effective ways of recruiting folks who are underrepresented in biomedical research, as long as they can ensure that that they have built trust with them. And then I think it's really important that we start ensuring LGBTQ+ visibility and health equity in all experiences of research going forward. So one of the things I would encourage you all to do is make sure you have pronouns on email signatures, that you use those pronouns in meetings and introductions, including the 1,000 Zoom meetings that we're doing these days, and that you think about including sexual orientation and gender identity measurements in any research study that you do, and including those in a table 1, even if you are not an LGBTQ health researcher. And I think everybody can help make that happen. This is not just me. There is a series of folks here. So again, Juno Obadamalaver in the upper left is the co-director. She's a professor of obstetrics and gynecology here at Stanford. Anissa Flengi in the bottom left is our associate director and is based at UCSF. She's a clinical psychologist. We have a slew of other folks engaged in community engagement, communications, operations, and making sure that participants really have a robust experience. And I think I would, we've received support from a variety of funding agencies and a variety of institutions as well. And I would just like to point out that we also have a really really a robust team of trainees who help us in every aspect as well. And so this is really from an undergraduate student through postdoc, really at every stage of kind of the standard university. So both undergrads, graduate students, medical students, postdoctoral students, and postdocs. So really a whole approach. And so with that, I would invite you to visit our website. We're on social media as well, and feel free, of course, to email me with any questions. And as I told Dr. Norwood, I'll be sharing these slides with everybody so they can get them as well in PDF. And with that, I'll take questions both. I see there's 2 questions in the chat box, which I can answer. And then there are, and if people want to share any verbally, that is also cool. And thank you again for your attention here. So so Meg asked, it's amazing that community partners are so involved in the study. Is there a similar impetus to connect with policymakers so that these findings can lead to policy level change? So great question. And the answer is, we hope so, yes. We've had some partnerships and collaborations and discussions with folks who do a lot of policy work, such as the Center for American Progress, which is a policy-based organization in Washington, D.C. And we hope that as we publish scientific papers, that those will get their way into policy related, to policymakers and policy hands. We do not yet have really a robust approach to get this into policymakers, and part of it occurs at the state level and part of it occurs at the federal level, and making sure that we will definitely want to do that. So always interested in ideas that people have, and so feel free, of course, to email me if there's policymakers that do this. I think that some of our community partners, that whole list of 30+ organizations, some of them are very involved in policy, and so we make sure that all of our research findings, of course, do get shared with them. But we do not have, say, a policy-minded person on our team who writes these up as more policy-focused briefs. But we are interested in that. Definitely policy level change is a desired outcome of much of the work that we do. And then Yona asked, the implementation of a PAC review seems so essential to non-exploitative SGM focused research. Can you speak a little more on the process of developing a PAC and some of the challenges you faced in maintaining PAC participation? Yeah, so yeah, I think the way that we developed a PAC initially was that we had folks from our greater network that we knew would potentially be interested in advising an important research study. So these were not necessarily researcher folks, but folks who cared a lot about the LGBT community and keeping it safe. And we went to them and said, hey, we're starting this study, we need this group, and would be delighted if you would be able to serve on that, given your expertise as a longstanding community member and somebody who has a little bit of an eye towards making sure that things are safe. And so that's really one of the aspects that we wanted to create. And then one of the ways to keep it really maintaining participation is that we let the group be self-governing. And so they created their own bylaws, their own functioning procedures, those sorts of things, so that folks really had buy-in into the organization. You know, Juno, the other co-director, and I don't attend the PAC meeting. Our community engagement director does. And so we've wanted to have a little bit of space that they weren't feeling weird power dynamics or other aspects from that. And so that's been a part of it, and we really try to be appreciative of their time and energies, and that partially includes paying them. And so we pay them a couple $100, $200, soon to be $300 a meeting. So that's a substantial amount of money over the course of a year for monthly meetings with 12 people. And so I think there's all of those aspects, really making sure people feel valued. We come to them when we have questions, and then we close the loop with them. When they provide us feedback, we close the loop with them as to how we use their feedback, which is, I think, the other important thing that doesn't happen much with communities. So great. looks like a couple verbal questions. Craig?
Yes.
Hi there.
Hi. How are you?
Great.
Thank you for the presentation. Really enjoyed it. One quick note and then a question. The quick note is, I study primarily young people's engagement with digital media and technology. So very interested if there may be some ancillary opportunities to kind of work with your population set there to maybe think about the ways in which digital supports their mental health care needs in particular.
Absolutely.
So I'll reach out to you on that note. The question is, I'm curious in terms of the web-based platform that you've created, what can you say about just the degree of engagement? So in other words, are people coming there at all for interaction and social exchange, information exchange, community building, or is it primarily where they come and participate in research projects?
Yeah, we built it, and I think what we desire for it to be the former, where people are coming and having some interaction, and that we initially built it to be primarily research participation, and we have not yet built out these other ways, and some of those things I think are ways that we're considering because they may actually deliver more value to people's participation, right? And there's of course a slew of regulatory issues and IRB related issues with that, because people need to have their privacy protected or not protected as they desire and as they choose. And so that is one of the things that we're thinking about, is making it in a way more of a social aspect. We do know there's a whole slew of stuff which I didn't talk about from the web platform that, we have a variety of email-based and text message-based reminders and interactive components where, we ask people every quarter if they're hospitalized, and we can do that by text message or by email based on whatever communication preferences people have. And so there's other ways that we're bringing people to both the portal, the kind of research participation website, as well as to the PRIDE study website, which is where we post the research findings, as well as a community-friendly summary of findings, which is written, not in scientific jargon, but is written, more at a 10th, 11th grade reading level whenever we can. And so that goes out through a variety of other communication channels, including newsletters and social media posts, and occasionally infographics and other aspects. So there's a variety of, things that are trying to bring people back, but there's not a lot of interaction between participants on the platform currently. Thanks for your question.
Thank you.
And if we have, I know we're at time, so maybe Ari, can we have your question, and then we may need to wrap up?
Sure. Hey, I'm Ari. I'm on the CST here for the Dell Medical School, so sort of similar to the PAC. But I think the question that I had is have y'all explored the value in potentially separating out like the difference between like being like a sexual minority versus like a gender minority? Like just sort of wondering if there's like the differences between like a Black trans woman are like super different from like the experience of like a gay white man, for example.
Absolutely, absolutely.
Yeah.
Yeah. So that's really a key component, and we are, we have now. I think there are 11 gender identity selections, and you can check all that apply. And there are 12 sexual orientation selections, and you can check all that apply, and you can also write your own in. And so these, as you can imagine from a scientific perspective, are complex analysis questions, right? How it is if somebody checks off, say genderqueer and transgender woman, how does that differ from somebody who selects cisgender woman, for example, right? And so really there's a slew of opportunities, and we're actually working now to suss some of these things out. We know that about a third of the PRIDE study participants are gender minorities, so there are numbers there to actually do that research, and we're and of course, there, as you point out, there's the intersecting identities with race and ethnicity as well. And so we're looking at the number of, trans feminine people of all different races and ethnicities, and starting to suss out whether or not we have the numbers to start looking at the experiences of, as you say, a Black transgender woman compared to a white cisgender gay man, for example, right? And looking at the differences there. We may we don't know that yet, and then we're actually, our analyst was actually just tasked with doing some of that work earlier this week to start, because we may realize that we may need to do some recruitment of some underrepresented racial and ethnic communities as well, and we want to make sure that they feel welcome to participate, and that they're going to that everybody is valued and provide some value for people's participation. So these, I think, are all the continued struggles of many research projects, including ours, is making sure that we have really the diversity broadly that we want in order to meaningfully answer some research questions that are not pooling LGBT people all together into one group.
Thank you.
Thank you. Thank you.
Great. Well, thank you so much, Dr. Lunn, for your talk. And like I said, we're going to make sure that we have your slides and your video available. And I know there's a lot of interest on the part of many researchers at UT here to collaborate with you. So hopefully we will stay connected. And I want to thank everybody for participating. Thanks again. We will be in touch.
Thank you so much, everybody, for your attention. It was really great to be here. Again, Dr. Norwood, thank you for inviting me, and looking forward to, please reach out via email for anything that we can help with, and looking forward to collaborating with folks.
Thanks so much.
Have a great weekend, everybody.
Bye.
Bye-bye.